the Friday morning House Appropriations Committee meeting. On the top of our agenda is the, we are going to start out with the budget of the Department of Vermont Health Access. And we have with us, we're doing a joint committee meeting with the House Health Committee. So welcome all of you. It's nice to see you. We have the administration here, and we also have Commissioner Gustafson. I can't say it because I'm on YouTube. I'm sorry, Corey. We have the commissioner here of DIVA with his team. And yesterday, the other committee of jurisdiction did hear that we are working off, this is a restated budget working off the 2021 proposal as submitted in January. And we are working to get you the ups and downs from the January proposal and the ups and downs from the restated budget, as well as refreshing everyone's minds as we go along of any possible language or changes that we were doing from the governor's recommend. So with that, Corey, we have now from 8:30 through 9:30, and then we have 15 minutes for committee discussion. So I'm hoping we can get through in an hour. And welcome. And if you'd like to introduce your team, that would be great. But before we start, Representative Lippert, you're the chair of Healthcare. Do you have any opening comments you would like to make?
No, just great to be here jointly with you. Let's proceed.
Nice to have you. Commissioner,
yeah, good morning, Corey Gustafson, Department of Vermont Health Access Commissioner. Good morning to both committees. I want to say good to see you. I don't know if you all feel how you feel about being back on the screens, but good morning. And I will mention from the department, Lisa Schilling is our financial director. She's on for any sort of technical questions related to interdepartmental transfers, MEG groups, anything that gets detailed enough that it's beyond my scope. And Sarah Clark from the agency is on as well. In case you have any bigger picture, probably global commitment questions. But I think we'll get going. Before I start, I think I'd like to know how you want to proceed, Madam Chair. That we have narratives and we have the ups downs that are standard to look at. So it's really up to the committee how you would like to walk through this.
What we would like you to do is to do your presentation, which shows the changes over the proposed budget as presented in January. And if you have it prepared, if you know of initiatives that were put on the table from January and you're prepared to say, this is still in place, this is still in place, this was an initiative, but we changed it, this one's off the table. As much as you can help us relate back to the January budget would be helpful. If not, we will fill in those gaps and compare the two budgets. And stop at natural stopping points at different sections to ask for questions from committee members from either appropriations or healthcare.
Sure.
So I would like you to lead the discussion so we know the changes and where the 21 budget is going in your department from you.
Yep.
And
it looks like Teresa has the narrative up, and let's work off that then. The big picture is of course we always have program and administration on this sheet. Program is the first segment we're going to talk about. The overarching element that's different. There's two things that are different, especially in program for us at DIVA and at Medicaid, is that with the pandemic, we essentially stopped doing redeterminations, and we're not removing. There were no people being terminated from Medicaid. There are no people being terminated from Medicaid. That continues today. That means, along with the economy, let's call it a slowdown, and the non-redetermination activity, we are picking up in a slowly but surely fashion Medicaid members. Population is growing, not at a rate that is In other states, it's been a really large expansion of population. Ours has been just kind of slow and steady. The last number I heard had in my head is about 8,000. I think it since maybe back to February, we're up about 10,000. But that's like the sort of ballpark of slow but steady increase we've had. We haven't had any real, in 1 month time, a large addition of individuals. So that's one piece, more people. Second piece that you will see in the numbers, the second piece is that the 6.2 federal match increase due to CARES Act is really the offset all of that. So there's more federal dollars offsetting the program increases. So yeah, Teresa, move up.
Can I just step in?
Changes.
Excuse me, I'm sorry, Commissioner. There's a lag
No
when
problem.
I'm talking and when you hear it. I just wanted to, the 6.2 is the FMAP bump.
Yes.
Okay, I just for other legislators, we talk a lot about the additional FMAP bump that has put us below, I think we're below 40% now for our match, which is significant. And this is the piece of money that is bringing in the extra $19 million per quarter, as long as we're still in a state of emergency as determined on the federal level. And this budget is built off an additional 19 million for the second quarter. We're in a state of emergency now, so we got the bump. We got the bump back in the 20 budget, and we got the bump for the first quarter of the 21. And this budget is built on the assumption that we will get that FMAP bump for the second quarter of 21. Is that correct?
Yeah, and I would actually say a little more than it's more than an assumption. The current state of public health emergency, state of emergency goes until October 23rd, which is into the second quarter. And the sort of the CARES Act says the 6.2 will continue to the end of the quarter that the public health emergency ends in. Presently, it's October 23rd. I did have this conversation a little bit with Senate Appropriations, and they were saying, what do you know about what's coming from the federal landscape in terms of funding and future opportunities? That's not a question that anyone can probably answer with any sort of certainty, but being asked, I think one of the places we landed in that conversation, so you're up to speed, is do we think, I think I'd answer it with a question, do we think that the public health emergency in the United States will be under wraps by late October? And probably a lot of people would say no. So there's a potential that if there's another extension, that the FMAP increase, that 19 million in federal dollars that you're talking about, Madam Chair, would extend into another quarter. And that would, obviously intersect with wherever revenues are at that time, general fund, all the other pieces. But I wouldn't say that's good news, but that is a piece as you budget that I was asked to sort of look forward, what could happen, what could change. So the end of the calendar year is actually not, it's not an assumption. I think we're pretty good on that.
And there's a possibility, a strong possibility, we would get it in the third quarter as well, but the budget does not reflect it. So that would be a budget adjustment issue.
That's true.
Okay, thank you.
Yeah. Okay. Teresa, if you could just move up a little bit more, and these are basically the factors that lead to the increase of population, and then and things we've done. So the first piece are related to the CARES Act, those first two bullets, extending the coverage periods and then not ending coverage in the emergency unless a customer requests it. That's just something we're actually really seeing right now. Like there are people that have other forms of coverage, but unless they actually say, I want to end my Medicaid coverage, we are not authorized to do so. That's a little insight to the daily operations. We're trying to navigate that and see how we can appropriately broach that conversation if necessary. Then the second part is pieces that have been done in the state of Vermont by DVHA, by Medicaid, related to these populations that they do have an impact on budget, but also, the offset or the reason we do it is to protect health insurance for Vermonters. So I guess let's move on to the next one. These are just a little bit in terms of enrollment numbers for background. You will see about a 10,000 overall increase from go back. This is, yeah, you're not getting the monthly increases. Sorry, not go back, go down. You can keep going by it. If there's questions on this, we're happy to talk about them. So next thing is clawback. For the last 3, 4, I mean, I think I've been in on budget maybe 7 or 8 times in my time here. I've always come in to tell you that the clawback was an increase in cost. This time it's a decrease. So the 6.2 reduces the clawback impact to our budget by $3 million. And I mean by budget, it's reduces state contributions by 3 million. So that is an assist to the general fund. All of everything FMAP, just again for context, everything that we get from the federal government is money that doesn't need to come from the general fund, and either allows us to as a state, and your committee and the legislature, to look at those dollars in a different way, possibly, or make up for lost or depressed tax revenues or general fund revenues to the state in this.
Corey,
Yes.
just for clarification, within the 19 to 20 million of the FMAP bump, does that include this $3 million of clawback, or is this additional on top of the 19?
I asked Lisa specifically. I believe it's all included.
It would be additional. It's not part of the AHS's global commitment.
Okay, thank you. That's even better news for us.
The next is, this is a policy conversation we were having during the session. This states that we have an up in our budget because of delaying the implementation of a preferred drug list management of the HIV/AIDS medications. I'm glad that the House Healthcare Committee is on. They were very involved in reviewing this with both the department and stakeholders. And this is in our budget as an increase because it was a $1.2 million decrease for a 12-month implementation. So we are projecting in this budget that we would begin this change on 1/1 of the next calendar year, so mid-fiscal year, and then that means that the projected savings would be $600,000 less. That's why it's an up and not a down. And again, intersects with what you stated off the top, Madam Chair, is that we're not working off last year's budget so that it's a down, it's an up because the up was higher in the previous GovRec. So I'll pause. This one is often a conversation, not often, but I've always paused to just see if there are any questions. But I'll say it this way: there is language that needs to change that we would have as a proposal, and have had as a proposal. And I'm going to say, with openness to a further conversation, that I believe this was on a path to being okay and approved by okay with the stakeholders and approved by the legislative committees, but I won't assume that. But it is in our budget. If we don't move forward with this, we would have to find the additional dollars.
This is a good time to stop for questions, especially why do we have to have this delay? And I will turn it. Representative Lippert has a question, and I want a refresher of how close we were to accepting this proposal. Bill?
Well, my memory is that our committee supports this. We did, as the commissioner said, we took testimony from stakeholders, and I'm honestly surprised that it wasn't in the Q1 budget.
The language never.
I've been operating on the assumption that this had been in place, but apparently not. Well,
thank you, Chair Lippert. The language was never finalized for approval, so we did not proceed. And that's the explanation.
Where's the finalized language needing approval in the appropriations process? Or in
I'm
another policy?
believing now that it has to fall into the, but I don't actually, I'm not up on what is going to be taken up by the legislature, but we would need this language in order to.
In the restatement language that was submitted to the legislature by Finance and Management.
And we will send out, Teresa will send that full packet of language out. It's color coded and it's really easy to follow.
So just, if I can just be clear that you need, who needs something from our committee, or do you need anything from our committee at this point?
The House Appropriations will want it in a very quick informal memo.
We can do that very quickly. We've taken the testimony, we've done the debate, and we're in support of this.
Right, but I want you to approve the new language, which you haven't seen. There's some tweaks to the language. So
Okay.
I want to make sure that
Okay, well,
fine with the new language.
thank you.
Will be in the budget.
Okay.
And so Teresa, if you'd send out the language to all the House members, that would be really helpful. And if anyone wants to listen in at 10 o'clock on Monday, Matt Riven from the administration will be in to walk through all of the language changes with our committee. So if anyone wants to jump in or ask Teresa for a link or jump in on YouTube, that you may find it helpful. Commissioner,
Thank you both.
did you have a follow-up, Bill, or are you set?
No. I just,
And Chair Lippert, we'll offer the follow-up too, if you want to have a conversation with us about what the language looks like.
so I would just request that if someone could articulate very clearly what the change in language is, because we had reviewed the previous language, so that we're not having to sort out what the.
We'll do that.
If there are changes, what's the change other than the time frame?
Right. Thank you. Okay, and then the next is again addition, the FMAP increase hitting our dish and chip populations, and this is what that totals to. It's $842,000 of general fund revenue that will not be needed. So that's the program side, up in people, so up in cost, but with the bump in FMAP. Due to the public health emergency and the CARES Act, we are using more federal dollars than state dollars on our entire population. So it more than offsets the increase in population and utilization.
I don't see any questions on the change in dish and chip. It's just related to the FMAP bump. So
yeah, when you see, if you look at the ups downs in your sheets, in the different fund sources, the global commitment, and then match non-waiver, there are places where these different populations fall, and so that's just the identification of two of those expenditures. Okay, so I'm going to move to administration now. The first is very simple. We have been in the state of a hiring freeze for a while now, and continuation of those freezes produce this in terms of savings or non-expenditures. I'm not sure I would necessarily just call them savings, but they are by not hiring into positions, we're not spending as much on salary and fringe. You can move up the page, Teresa. Thank you. So contract changes. These are. Yep.
Corey, I was muted, so I couldn't jump in. Are you, with the hiring freeze, do you have the capabilities of doing all the work you need to do, or is this putting any strain or stress on the agency to get work, especially with the Medicaid population increasing?
So operationally, it's a great question. Operationally, with not doing redeterminations and not doing basically a lot of the things that we normally do, I will say it's okay. If the public health emergency ends and we move into open enrollment, or we move into restarting redeterminations, the workload would probably be greater than what is necessary to manage that, but we would be in a different situation at that time. So I think it's not knowing when the public health emergency ends, not knowing when redetermination starts, trying to predict anything related to that is very difficult. So we have, it's a good question because it's the same horizon we're looking at. So when there's an assumption, I guess, that we're going to have to cross that bridge when the public health emergency ends and we restart determinations, and that could be a conversation in early 21, or it could be next fiscal year. It's hard to know when that starts, but you're really on to what we're looking forward to operationally. When we have to start the work again, the people will be, we'll do what we have to do. I mean, the governor has often said, we're going to take what we have in revenues and expend and money to expend and match that accordingly. And it may affect how well we're able to execute, but we'll have those conversations all along with the administration and with the legislature.
Thank you, Corey. So if there is pressure, you can address it in budget adjustment or in the 22 budget proposal.
Yeah, and forward looking, I mean, it feels like, this kind of meeting in August aside, it feels like we are regularly coming to the legislature to talk about what's new, and that would be something that would be a change. So yes, those are the next two stopping points in our budgeting is BAA and the next budget cycle. Correct.
Thank you, Corey. Before we move on to the contract changes, does anyone have a question from either committee? I don't see any, Corey, so let's move on to contract changes.
Yep. Okay, so the first is an increase to our WEX Health contract. They are the entity, as you I'm sure know, this has been in and out of our budget for a while. We are really, really, really close to executing on the transference of the premium processing responsibility to the insurers. As you see in the explanation, the pandemic delayed us what I would characterize as weeks, and just put us up against the open enrollment timeframe where we just couldn't execute. We had essentially people and resource limitations that didn't allow us to get the premium collection activity transferred over for 2021. It's a calendar year start for this activity. And so, we're projecting for this savings now to be a year later. It's unfortunate, but the few weeks or a couple months that we got delayed on this project produces a 1-year delay. So we have to continue to have it in our budget. I mean, on the I guess if you want to put a silver lining on it, it's more methodical, and we have a bit of time to make sure we get it right. I will say it that way. I'm looking for some positivity to it, but it is unfortunate that the pandemic really hit us when it did, because we were on a path where we were going to achieve. I will say finally. If you want it, you don't have to. Then I would say finally moving this piece finally off of our GovRecs and our budget adjustments. The next is the Maximus contract increase. This is another one. This is a little bit like the PDL conversation. We had in our GovRec for FY21 an $817,000 down. We still have a down, but it's not the 817. It's $565,000 less than the 817. Did I say that right? I think I did. So it's still a down, but it produces an up in this because we're working off the GovRec. Basically, what happened is the budget was built late in 19 while we were, I would not say we were necessarily in the negotiations yet, but the recommendation was based off annual, we pay by the minute to Maximus, and by our annual expenditures over the last few years, this was sort of the 817 was a recognition based on our contract, based on what we had actually spent in minutes. We could conceivably reduce our Maximus budget by 817,000. The excuse me, the total contract is for higher than that. We just didn't use all the, we were becoming more and more efficient, I would say, with our call center in terms of the process improvements. And so what ended up happening was a negotiation that began really in earnest probably February of this calendar year. So after the budget was introduced and proposed, long story short, it was going that Maximus had about $1 million increase to the max of the budget. We had to make some changes, but negotiated pretty, in good faith, both with Maximus and the state, but got that number still below the original contract. So this kind of identifies where that contract is at now. It doesn't really have any kind of prediction of what our utilization of minutes will be. We'll have to see that. There's a lot of, a budget's a budget, and the actuals are the actuals in this conversation, because to the same conversation we had about staffing, if we restart determinations, right now, Maximus, the call center, has been very manageable in terms of calls. But if we start doing the redeterminations, we would expect calls to jump back up. So again, we can budget off our contract, and that's what this does. But really knowing what our utilization over the next 9 months is going to be, a bit more of a challenge than that, and something that a little bit like if we start redeterminations before BAA, we'll come in and maybe have something to tell you then, or it will be in the 22 budget, what we would be seeing, and would have that conversation then. But just a little bit of a foreshadow into an explanation of how the contract looks like this, and that it is still a down from FY20 budget, but it manifests itself as an up because it's not as much of a down from the GovRec. So
thank you, Commissioner. We do have one question, Representative Feltus, and then Representative Lippert.
Please.
Marty?
Yes, thank you. I realize you have a contract, and so there's nothing that can be done about that now. And this is just an additional observation. We've seen, obviously, you use Maximus, and DOL used Maximus, and I think there are other departments that use Maximus for call center usages. Back in the beginning, before you began working with Maximus, did we have some more comprehensive looks at other possible vendors? It just kind of irks me that we're spending all this money to outside vendors when I would hope there would be a local vendor who could help us do this. Can you give me a little background on how that got started?
It's interesting because the conversation before we began was about how long everybody's been doing this on the committees.
Oh.
And I think our relationship with Maximus goes back to the 90s. So I was definitely not around at that conversation time. I think, honestly, Rep. Feltus, we would really be open to an examination of what is out there in the marketplace in terms of call centers. I will say Maximus has been a great partner. The team that is there is a team in Burlington. There are people that are employed, Vermonters that are employed by Maximus in the Burlington area. That team has worked really well with us through some pretty difficult times. So that's just a comment to the relationship with that entity, first of all. The second thing, though, is in principle, I don't have no disagreement with you. I think we keep running into the theoretical of, hey, it would be great to put this out to bid and see what else is out there. And then, then there's a pandemic. Then there's there's always just something coming along that makes it, well, let's get through this next time period, and then we will get to that examination of the marketplace in a year, in 2 years. I'll just say that as sort of the issue with how I agree, but operationally it becomes a little difficult.
Okay, I understand. It's just an issue that has been raised to me on 2 or 3 occasions. Thanks.
Very, very reasonable, and something that is actually, I mean, it's on the whiteboard examining it. And we have 108 or 9 agreements at DIVA that we are constantly monitoring and re-upping. So it isn't just a Maximus conversation. It's one of these conversations that we have on a regular basis with all of our vendors. And then sometimes we'll put something out to bid and only the one vendor will put a bid in. So I appreciate the comment and really want you to hear that we are very interested in that sort of activity at DIVA.
Thank you.
Thank you, Marty. Representative Lippert?
Well, first, just a quick note of jargon. It took me a few minutes. I think I understand what GovRec is, and I think it's the governor's recommended budget. The governor's recommend, is that what?
Yeah, thank you.
But it's a little bit of appropriations and DIVA jargon that I think maybe should be translated for others who are participating or listening in. And in terms of Maximus, I'll just second Representative Feltus's comment that some of us that while it appears from what you said that there's a good relationship with Maximus, I think many legislators do not feel similarly about the relationship with the Department of Labor and the enormous amount of money that's being paid to Maximus, and compared to the results that Vermonters received as a result. So one of my questions is, because it didn't occur to me till just today, because in Joint Fiscal Committee, we also, there was approval to use CRF dollars, I think, to contract with Maximus for the Agency of Commerce and Community Development as well. Is there a single contract with Maximus, or does each Department of State government contract and negotiate separately?
We have our own contract with Maximus. There was actually a question early on in the pandemic and the emergency, could other departments sort of tag on to our contract, and the examinations, basically kind of turned back no. I mean, part of the Maximus, I would say, complicating factor is, as you know, in Medicaid, a dollar includes the state and the federal dollar. So unwinding that for a state agency that's paying in with non-matched rate dollars, it got a little complicated. So the simple answer to your question, and each has its own relationship. I mean, it's different people too, of course.
Right. Okay. Thank you.
Thank you, Bill. Commissioner, could you tell me how long a contract you sign a contract for? How many years?
I believe this one is 5 years. Lisa, does that sound like the latest update is 5 years? We have some opportunities for discontinuing relationships in any contract, but
yeah, it says a 5-year amendment with Maximus. So it's. I'm sorry, I didn't catch that. But my question is there any requirement to put these contracts out to bid? It's like with other pieces in state government, depending on what the threshold is, with studies and so forth, we put them out to bid.
Yep. There are, and in situations, especially this one, we asked for a waiver of that requirement, basically because of the risk that it would, we were in a position to be negotiating this fairly closely to the time when the contract was up, and the risk of a changeover, which is regardless of when we were negotiating, the risk of a changeover is always something that's on our minds too. And And so, yes, there is a requirement.
Representative Lippert.
What is, this is the increase. What is, maybe Lisa or Commissioner can tell us, what is the total contractual amount?
Just over $7 million
Thank you.
annually.
Right.
Thank you. Probably this is a conversation to continue when the 22 budget is brought before the legislature to look at contract negotiations and perhaps starting them earlier. Is there, I mean, can you?
Yeah, totally. Honestly, a little bit of a, this gets right back to the conversation about there's in theory and then there's what happens. And if you're looking for a 2-line explanation, changes in leadership on the team, and, in just not ready to, it's a big deal to put out an RFP and to be able to really know what you're looking for, know what the difference between one contract to another looks like. And in mid last year, we had some pretty significant leadership changes in that unit, in the team that manages that contract. And it felt like more risk to engage in something that, as I said to Rep. Feltus, as Chair Lippert has discussed, and your point is good, Chair Toll, that it felt like more risk to the operation than we could really stomach at the time, given the newness of the leadership team that was really taking over at the HAYU.
I can appreciate that. But as the team is seasoned, these are something that we hope that will be seriously looked at.
Yeah, we just hired a new director who came to us. I think she's in her 2nd week now. So I agree completely.
Let's move on to the next contract, please.
Okay, archetype contract increase is, boy, this one can get pretty wonky pretty quick, but essentially we have a lot of reports that archetype produces for us. In the neighborhood, I'll say 700 about that have been produced by archetype over the years. About 130 of those are for CMS reporting that we need. The other, well, it says right here. So the others are for us to actually run our business. So they're process reporting that are used for us to do the work that we need to do related to enrollment and eligibility. And essentially what happened was Oracle was updating their system. So all of our work all of our reporting wouldn't work anymore. So this conversation goes back, I want to say almost 2 years. And ADS had proposed that they would take over the project of reporting and sort of reconstruct all of these reports by essentially, I'll call it reverse engineering. Over time, the complicated nature of that effort just demonstrated itself to be too great. And so in February of this calendar year, we implemented a contingency to get Archetype to update their business intelligence and the reporting to function with the Oracle platform, and to get really to Chair Lippert's point, to use acronyms. Just so in case you've heard this word, this is the OBIE OFI cutover. For any of you that have heard those terms before, for those of you that don't, I've just explained it. It's an update, and we're moving from one system to another. It's basically us continuing to rely on Archetype for these reports that are necessary to do our work and to report to CMS. And it's going to cost us, more, as it's shown here in the itemization. But there's an offset to, as we continue in this, in our we had in the proposal that we would reduce archetype. There was a proposal that we would increase payments to ADS. So, that there's a little bit of it isn't just a pure increase to archetype. It's just, we were trying to bring something in-house to the state, and it didn't work the way that it was, I would say, proposed by ADS and by, it was hoped for. How's that?
So ADS is a working partner with ADS in this change.
Any of these technology projects is a partnership with ADS, and that goes across state government, but we work closely with their technical resources, and they are they come up with ideas of how they can, I'm sure you've heard this before, reuse platforms and efforts across the different departments and produce a little bit like Chair Leppert was referring to. Does everybody have a different contract with Maximus? The goal is to be a little bit more, there's a word I can't think of right now, but to use elements of our business in other parts of state government in our business as well. So I think that this was a little bit of that, trying to bring it in-house and save some money, and it just didn't pan out because it was too complicated.
Thank you, Corey. We do have a question from Representative Christensen.
Yes, and my memory may be hazy on all this, but I remember, I think it was last year or the year before, where you mentioned a lot of these contracts were recommended, these companies were recommended by the federal government, and that we really, I don't remember them as being free, but the federal government was picking up the bulk of all the expenses. Is this the one?
No, it isn't, Rep. Christensen, but you're in the right ballpark. There was a move. Again, you are going back a couple of years where a different form of procurement was on the table, and the federal government was recommending that we engage with a couple of different firms to really push that along, and so those are different contracts.
Okay, thank you.
It is related to integrated eligibility, or was related to integrated eligibility, but that's a couple of years ago.
Okay, thank you.
Thank you. I don't see other questions, so let's move on to the Burns and Associates.
That's an increase in our Burns and Associates are our payment consultants, really top-notch experts in the field of healthcare reimbursement. We are engaged in payment reform activities across the agency, and the more these payment reform efforts take root in certain areas, the more other departments within our agency are saying, hey, we might have a good opportunity here to pay for healthcare differently or pay for services differently. Can your team engage with our team, our program teams? And this is DMH, this is Dale, even DCF and VDH. We're really looking at efforts all across, and as these come forward, it does involve consultation with Burns and Associates at a higher level. So their budget, or our projection for their budget is an increase in the next year for those reasons.
Thank you. I don't see questions there.
The next is a one-time reduction to the DXC contract. DXC is our MMIS system. That is the system that pays claims, enrolls providers, really is the sort of system backbone to Medicaid. It is a fairly substantial contract. And when we knew we were in a resource downturn, a state revenue downturn, general fund sort of pressures, we turned to a lot of our vendors that had fairly large contracts and essentially asked them, what can you do to contribute to a reduction in our contract, and DXC stepped up. So a great appreciation to them for this, and it essentially there isn't necessarily anything particular. There's a little bit of, we have some money in our contract for change orders. I think there's a little bit of thought that's a little bit of a place where we will save, but more than anything, it's just them being good partners is how I would characterize that.
Commissioner, was the department given a 3% target for savings?
We were. I'm not actually sure what the reduction in our. I mean, there's our overall, and then there's the GF, right? That's the funkiness of our contract always. But we were. What I will say though is that the 6.2 has created. I'm not actually sure what the percentage savings in GF that come from the increase in 6.2. Maybe that's something we can get to you, but we were given the target. What I think ended up happening was, an appreciation from the agency that in this time, making sure that providers were not affected by the change in any way, shape, or form, as we are in the midst of a health pandemic. So no change to provider. The other part is we don't really have flexibility in terms of changing services or population. Those are the other two places that you might make a change in a Medicaid program. With the 6.2 bump, we can't change that as part of the agreement. So
I appreciate that. I was wondering if you had a 3% target, even beyond the 6.2, the savings you're able to realize because of that. And I was wondering if this DXC contract, if you were going out to these contracts to try to make the changes to reach that target. Was that an independent?
We were making the changes because we didn't know. We were making these requests before we had a finalization of the conversation always goes, the department, the agency, the administration. And before we even knew what we did know, we were working off what we did know. And what we did know was the general fund projections were for less money, knowing that our expenditures begin with the general fund and receive federal match, that we didn't want to not leave stones unturned, I guess is how I would say it.
Thank you.
Yeah.
Before we move to the changes in operations, are there any final questions on the contracts from any members? I'm not seeing any, so we'll go down to your final changes.
Okay, so these are internal service fund obligations, reductions, 122,000. I don't have a ton to say about them. If there are questions, I'm happy to either get the answer or have Lisa speak to them, but I'm going to move on.
We're clear in all the budgets with the 5% reductions in ADS.
Yeah. And then I've already kind of explained this one was anticipation of ADS taking over and billing us for business intelligence activities. That's the reporting that Archetype does. And so that this is there's also some dollars in here. You'll note that it's not a 1-for-1 in terms of the total spend, but we also had some spending authority that had been in our budget that we weren't spending on an annual basis that is essentially going away from the federal government. So that sort of finds itself into our budget here as an additional, you can call it savings, but it was really just authority that lived in our budget in case we had the match rate, the state match and the projects that are appropriate to spend on.
Thank you. A question from Representative Hooper.
Thank you. Good morning, everybody. Thanks for your presentation, Commissioner. I am wondering what you are concerned about looking forward. It strikes me that your budget is one of those places where, as the deep distress to the economy plays out, that you're going to see the repercussions of it, and the federal emergency will go away. And so we won't have the FMAP bump, but you're going to have additional pressures and not have the adjustments from the feds. Can you help us think about how to, and that's a big question and we'll deal with it in the future, but how are you positioning yourself to address that?
Yeah, I mean, I couldn't say it a lot better than what you just did. I mean, that's, you've really hit the nail on the head. I mean, that's the Agency of Human Services. That's the, you know, the conflict or the dichotomy, whatever you want to say, the opposing nature of when the economy falls, general fund revenues fall for the state. That's really, you know, to the state. But when the economy softens or depresses, human service, you know, is and the programs and services we provide are in greater need usually, right? So you basically characterize that in your question. That is the, you know, the concern across, I think, the administration, Agency of Human Services for sure, the other departments, but it's the simple answer is, you know, we're not like the federal government. We don't print money. So as the revenues and expenditures continue to diverge, or as we move forward, we will continue in, as Chair Toll mentioned earlier, we'll continue to adapt to, here's what we have in terms of funding, and here's what we have in terms of expenditures, and make proposals that can, you know, end with a zero, at least in projection, right? There's always how things actually go in between the times when we are discussing our budgeting. But I don't have a silver bullet for you that says, well, we've got it under control. I would just say that, you know, we've managed both ups and downs in the state over the last little greater than a decade, and we would continue to do that. I think Vermont's shown itself to be very aware of the needs of the population in a downturn of the economy. I would also say it does appear, and this is now we're into a little bit, I mean, we are in this sort of look forward, and nothing is for sure. The conversation going on at the federal level are definitely something that we're interested in, of course, right? What we do know about the 6.2, what we know about the public health emergency and the state of emergency as currently declared, those are things we can talk about. But there's also this conversation going on about what's the next round from the federal government of support for local and state entities. I think we've all heard those stories. Impossible to predict where those go, but that's another part of the process and being aware as we move forward.
Are there things, can you take advantage of CRF money that will position you to, will put you in a better position to address the inevitable revenue decline? So can you, for building out better systems, IT, that sort of thing, are there things you can be doing now with CRF that will position us?
Yeah, so CRF, increasingly, not surprisingly, probably to you all, CRF gets increasingly prescriptive as how we can use it. And I would say that just as a proper anticipation by the state, let's call it. The administration has brought on a consultant to advise. You know, the federal government is great about handing over money and then coming back and saying, how did you spend it? And so we're doing everything we can to not be in a position in the future to have to give those dollars back. As you mention IT, it does make me think about all the projects that have been underway for a long time. So anything that we would want to do quickly seems like a tough one, but we're not again, just like I said about the contracts with our vendors. I won't say there's any stone that we don't want to look under and say, is there opportunity, or just, out of hand dismiss something. So we're always open to that, but we do have a finite amount of resources as it pertains to IT with our ADS partners, with our own team of program managers. And so we have finite resources that if we, it would have to be the juice on those kinds of activities would really have to be there for us, and not just be, we really think something might be good if we do this. That would be another sort of generalized consideration I would throw in. I will say that in CRF, obviously, maybe this is for those that haven't, seen it, but I'm sure you have. Provider stabilization efforts, the hazard pay efforts, those are all to try our best to make sure that during a healthcare pandemic, that our healthcare providers are not being exposed to extraordinary pressure. This is, of course, as utilization changes. I mean, in some areas, I think that utilization is really back to normal, whatever you want to call that. But I think that the amount of money that was set aside by the legislature is one example of where those CRF dollars are assisting really what we need as a Medicaid program or as DVA, which is access to healthcare when needed.
Thank you. Mary, did you have a follow-up or?
No, thank you.
Representative Iacoboni?
I think we're just about out of time, but I'll try to be brief. What is your primary method for controlling per member per month expenditures?
We have a fair number of efforts underway, right? With all of our different payment models, trying to produce better outcomes for and purchase differently. We have engaged with the biggest, of course, being our relationship with the Accountable Care Organization as part of the all-payer model agreement, and looking to push delivery system reform so that there is greater alignment in the healthcare system and less and better incentives for providers to produce and to act on in those prospective payments that we are making. And we've seen on the prospective payment side, we've seen good results in terms of shadow claims showing when we pay a prospective payment, utilization is down. I think that is speaking to what our big sort of overarching goal is to purchase healthcare differently. We do still have some prior authorization and in place. We've been exploring reduction of that because of the incentive changes. But prior authorization is also aimed towards patient safety, so we don't want to completely give that up either. But I think that's the short answer, Rep. Iacoboni, to your question, which is purchasing healthcare differently is really, and not having that incentive of fee for service as the primary incentive, because we've seen it time and time again. If you pay on a per click basis, you're going to get clicks, and you don't necessarily. And again, that might seem theoretical in this conversation, but as you said, we really are focused on purchasing value, not volume.
I guess, thank you. Not for today's agenda, but in terms of budgets and driving costs, we'll talk more in the future about the ACO and the relationship to helping with outcomes. That seems to be significant investment we're making, and I want to make sure it's working. Thank you.
Absolutely. Yeah, no, it's a great comment. I appreciate it. It's, you know, we've always said that this is, there's a theory behind the case. I think that if you go at the beginning, you say, should we leave the healthcare system alone, or should we try to change it? And we've tried a few different ways. We've looked at different modeling, and we've had things like the blueprint for a long time, but there's a lot more healthcare system out there than just the primary care, you know, piece of the puzzle. And this is our current best effort to get, you know, all of the different kinds of payers in a very diverse system of healthcare into a more aligned methodology, both for the payers and and all the different providers we have in our system. So the examination of its effectiveness is something we're very interested in as well. We've always said this is definitely a test of what would seem to most people. I think a lot of people have talked to a sound theory, the incentives of fee-for-service. This is a national sort of perspective that the incentives of fee-for-service don't necessarily produce the best outcomes. So, you know, our efforts around an all-payer system and an accountable set of providers in a network is something that we think is worth testing. So I appreciate your vision towards evaluation, because that's on the list as well.
Thank you, Commissioner. Dave, did you have a follow-up, or? Thank you, Dave.
No, thank you. Thank you very much.
We have two final questions, and then when you finish with those questions, Corey, we're going over a bit on time, so I want to be respectful of your time. Not to discuss, because we've discussed them in January and February, but if there are highlighted initiatives that are still in play that have not been changed since the since the January proposal, if you could just give us those topics, and if you can't, Dave and I will be working on finding those. But we have a question from Representative Page, and then Durfee.
Yes, this might be a little bit out of our scope, but it does go along with what Representative Iacoboni said. Your agency is responsible for, I guess, putting together plans for essential health benefits regarding various MVP and Blue Cross and Blue Shields, but yet we see some of those costs going up. How do you maintain and keep those costs down, and yet provide the essential services that we need for Vermonters?
Yeah, it's a great question. I mean, I think this is a long kind of conversation. If I wanted to answer it in short form, I mean, really, the costs, you're now in the world of commercial insurance. Qualified health plans are, you know, we do have an intersection with those. They are the commercial insurers paying for healthcare on behalf of a population. How we keep those costs down, I mean, that's the intersection with the all-payer model in one aspect, wanting to get some greater alignment in terms of overall healthcare and how it is executed on the delivery side by adjusting payment. You know, maybe a little bit of an editorial about it is the cost of those plans are the reflection of in a simple format, a reflection of the cost of healthcare in the state of Vermont. Those increases reflect increases. That's why I will say this, that those increases and their necessity are up for debate, right, in front of the Green Mountain Care Board. That's what the Green Mountain Care Board's job is, to evaluate both the necessity of increases, the cost of increases in healthcare through the hospital budget process and the insurance rate review. And of course, there's another intersection where DFR is responsible for, you know, certifying that the solvency of those insurers is adequate, would be protected by the rates that the Green Mountain Care Board approves. So DVHA does have an intersection on the certification of the plans. We have not certified plans before. Last year, I believe we certified all the plans that were priced and approved. 3 years ago, we didn't approve one because it had an impact on the lowest cost silver plan, which is how the federal subsidies get determined. And by not approving that plan, we were able, I think, to secure an increase in the amount of federal subsidies that came to Vermonters within the FPLs that were getting subsidies on QHPs. So we do have an intersection, but the overall, I mean, I think you have a bigger question that is a really good one. It's just, you know, I mean, this goes back almost to Rep. Yakovon's question. I mean, the cost of healthcare in the state of Vermont, the cost of healthcare in the country, what are we going to do about it? And I think we're all asking the same questions. We're doing something about it on the basis of an agreement that was signed in the end of 2016. And we're testing a model right now to see if it's going to really produce the kind of delivery system evolution that we're hoping for.
Thank you, Commissioner. It's a much larger question than we'll tackle at this point, but a very important question, and certainly one we look forward to continuing in when we come back for the 22 budget, but also initiatives that can be put in place. Thank you, Representative Page. Did you have a follow-up? Thank you. Representative Durfee, and then we'll close with Representative Lippert.
Yes, thanks. I know we're running over, so if this is a question that can't be answered quickly, Commissioner, I'll be happy to discuss it later with you. But it's a cost question, and I'm looking at the caseload section of the document that you had addressed earlier. Tell me if I'm doing the math right. About 15 million in additional spend, and about 1,000 additional in the caseload. So, which would come out to about $15,000 additional dollars per added caseload.
I think you might be missing a zero there. Am I, Sarah? Not if I'm. I think we're closer to 10,000 in increases. Is that what did you say? 10,000 or 1,000?
In the caseload, I thought I was seeing 1,000, and what I'm doing is comparing 100, the bottom row, the two right columns in the caseload.
Yeah, it is absolute. Go ahead.
That's the average enrollment from state fiscal year 20 to what we project for 21. What we were seeing before the pandemic was a regular decline in our Medicaid population, and had originally projected that that it would continue. So that's the actual decline pre-pandemic was greater than what we had thought it would be in 21 as we head into 21. And the number Corey is referencing, the commissioner is referencing, representative, has to do with the difference between actual enrollment in February as to today. Does that make sense?
Not entirely. I'm not going to pursue it right now, though. Just let's talk about it. Let's talk about it later.
Yeah, I also just say that this is the consensus forecasting that happens on I don't know what the cadence is, but it's a regular effort between JFO, the administration, and AHS to come to the forecast agreement about populations, what the projection for enrollment is and utilization.
And just in terms of the dollars, though, so that I understand, make sure I understand that piece of it. The 15,121,000 represents the difference between what was in the recommended budget in January and what you're now recommending.
Correct.
For program and for utilization and caseloads.
Caseload utilization.
People and what they would use. Yeah.
Okay. Good. Thank you.
And there'll be follow-up for you, Representative Durfee and Representative Lippert?
Yeah, very. Just quickly, you mentioned, Commissioner, you mentioned that by virtue of not doing redeterminations at this point, there are indeed Vermonters who continue on Medicaid, but who actually have access to other insurance. Do you have any estimate of what the additional costs are to Medicaid? And is it primarily commercial insurance that is reaping the benefit from Medicaid paying instead of them?
Yeah, I don't know that, and that was a little bit more anecdotal than it was, some sort of grouping of population. We don't know. We know we can't take people off. We do know people are asking in some cases, but it's very anecdotal and not something that's a population or a pocket of individuals that we know of. They move. I mean, it's not something that we could necessarily pull.
It's not something you're prepared to quantify. Okay.
Thank you. Good question though. So just very quickly, Corey, without getting into the topics, because we have heard, the testimony and it's been debated back in January and February. Are there initiatives you could just remind us of that exist in the budget that we need to make sure we've made our final decisions on? I know that the preferred medication list for, HIV.
Right. That was one. The other is the WEX, the premium processing that gets, sorry.
We've talked about the WEX.
Right. Yeah, no, I don't have any that are on. I'm looking at the list now for administration and I don't see anything that we haven't talked about. Excellent. Administration from the original proposal of 2021. So I'm not, I don't see anything on this list as far as administration goes or program that would be anything we didn't discuss. Even our governor recommended budget for 21 was pretty streamlined as well. We had that PDL and we had the transference of premium processing. So
we've covered those. So for the committees for the healthcare committee, the things that we'll be looking for in the DIVA budget would be that you look at the new language and make sure that the new language fits your needs. The hiring freeze, if you had any concerns about that, and then the changes in contract. I think that we've gone through all of those questions. And then we have the typical changes with the internal service charges and then back in the 20 budget, the natural pressures with salaries and fringes and we will look through all of those. But I think that this was one of the budgets that we were pretty close to being complete on. And if there's any other language that you had out there that you want considered, if you could as quickly as possible, that would be wonderful.
Okay.
And if someone from DIVA could articulate to Jen Carby or our staff the specific changes in the HIV/AIDS language.
Yep, I was just going to say that. Well, we will ASAP. The only
Jen's on, so she heard that. I think Jen is on. Yes, she is.
Okay.
Hi, Jen.
The only other is Rep. Lippert. The only other comment I have on the sort of Medicaid and other insurance is that we do have coordination of benefits unit that's their job to make sure that Medicaid is the payer of last. So if it's not, if there is any significant amounts in that category, that we would assume that unit would get at those numbers too. So just to sort of add to that conversation a little bit, maybe add a little bit of comfort that it isn't just lost Medicaid dollars.
I'll ask some follow-up questions offline.
Okay, please. Okay.
Hey, thank you. I think that this brings us to a close. Representative Lippert, did you have any closing statements or are you set?
Again, just to say, I think this was a helpful process and possibly something we might want to think about in the future, actually, rather than just seeing this as an interim step between our committees. I think this is actually a productive use of our time.
Yeah, I find it much more productive and we're not duplicating efforts and we're hearing each other's
We're hearing
questions.
each other's questions. I think it's a valuable thing, and I hope we might want to recommend it as a way to proceed in the future.
Thank you. And not Representative Gustafson, Commissioner, thank you for coming. Lisa, thank you for coming in. And we are going to have to sign off because we have to come in new at 11 o'clock committee. We are
10 o'clock.
at 10 o'clock. Boy, my morning isn't going as fast as I thought. At 10 o'clock, we're coming back in to hear from Commissioner Baker from the Department of Corrections. So thank you, and we'll see you all in about less than 15 minutes. Thank you.
Okay, I'm stopping the live stream now, Madam Chair.